Good evening, everyone. How are you all? Okay, so tonight we're going to start surgery. So as you might have noticed on the Facebook that we're taking surgery class, like there are 3 surgery class basically. So one is today, and then there are 2 orthopedics class as well. So those will be our 3 surgery class. Okay, so for for surgery preparation, John Murtagh doesn't have much. So, especially about the general surgery is mainly discussed with medicines chapters or during our question solve classes. So there is not much to go through from general surgery, and the chapter that we have done from acute abdomen in medicine GIT, that is the chapter that mainly fulfills your general surgery chapter. Okay, so not much to go through general surgery, but as from surgery point of view, we mainly go through the trauma part or emergency management part. So in terms of trauma in surgery, there are a lot of important questions which comes in exam, but there is nothing there in your John Murtagh. So main thing you need to go through for surgery trauma topic is Kaplan step to CK. Okay, so we are mainly following Kaplan step to CK for today's class because there is a lot in Kaplan step 2 that you need to follow. Most of the time I will go through Kaplan step to CK. We couldn't, like, usually if we need to put it in a note, the whole Kaplan step to trauma part, we need to just bring it in the note, which doesn't make a lot of sense. So all you need to do is to go through Kaplan step to CK after the today's class. So the trauma is the main part of our tonight's sessions, and there are a few other things that we are going to discuss as well at the end. So I'll open Kaplan step to CK so that you know from where we are discussing this. So if you go to USMLE step to CK surgery, you will see that there are 2 sections. One is section 1, which is the surgery theory discussion, and then there is a section 2, which is surgical vignettes. Surgical vignettes is very important once you go through this trauma chapter. So in the trauma chapter, we will discuss each and everything that comes in exam. But after we discuss the trauma chapter, you need to go through these surgical vignettes. In surgical vignettes, they have given questions. So if you see here, everything that we are going to discuss today, there are some questions they have given in these chapters. So in the section 2, you will be able to go through some of the questions, and then they have explained the answer of that question. So if you can go through all of this, at least the trauma chapter, your basic for surgical questions will be really good. And that's all that we want you to do. Okay, so your preparation for tonight's session is mainly go through what I am discussing today. And after that, you just need to finish these surgical vignettes by yourself. Okay, so you just need to read the questions, think about what could be the answer, and then read the explanation. Not the full, just the trauma chapter. Okay. Now coming back to the section 1, trauma chapter. So any patient who comes to you after a motor vehicle accident or a road traffic accident, the first thing that we do is primary survey. So primary survey includes checking the airway, so A, B, C. So mainly airway, breathing, and circulation. So the first thing that we do in a patient who presents after a trauma is airway checking. So the first step in the evaluation of trauma is airway assessment and protection. So any patient who comes to you after a trauma, especially motor vehicle accident, the first thing that you will check whether the airway is intact. How we know? If a patient is conscious, is speaking in a normal voice, that patient's airway is protected. But if you see that patient having a noisy, gargly breathing, if patient's GCS less than 8, which means patient is unconscious, then there is a likely possibility the airway is not protected. So an airway should be secured before the situation becomes critical. So in the field, so let's say you're not in the emergency theater or you're not in the ED, so you're in a field where the accident happened. So in the field, an airway can be secured by an intubation, or if intubation is not possible, then cricothyroidotomy. And it means that you need to give something so that the patient can breathe in and out. So in the field, many times intubation can be difficult, but if intubation is not possible, then you would go for cricothyroidotomy. How about emergency department? In emergency department, you should be able to do intubation in this patient. So orotracheal or nasotracheal intubation will be the ideal choice. In the presence of a cervical spine injury, orotracheal intubation can still be done as long as the head is secured and inline stabilization is maintained. So as you know that during intubation, you need to extend the neck of the patient. But before you do that extension, you need to make sure that there is no injury to the cervical spine due to the trauma. So make sure that you rule that out before you do that extension of the neck. But even if the patient is in a cervical collar because of cervical spine injury, you can still consider doing a orotracheal intubation, but you just need to maintain the neck straight. You can't do too much extension in that case. So if orotracheal intubation becomes a bit tricky, you can try nasotracheal intubation. But there is a time where you can't go for intubation, especially if there is a maxillofacial injury. So if a patient has got severe facial injury, then we can't actually go for intubation. In that patient, cricothyroidotomy will be necessary. We normally don't do tracheostomy in adult, but in pediatric population, tracheostomy is preferred over cricothyroidotomy because in children, cricoid is very small than adult. So, so what we had discussed in the airway is that first thing is that any patient after trauma, you need to assess whether their airway is intact. And if the airway is not intact, you need to go for intubation or cricothyroidotomy. Intubation can be done as orotracheal or nasotracheal. Even in cervical spine injury, it is possible to do intubation. And if the patient has got severe maxillofacial injury, then we would not do intubation. We would rather go for cricothyroidotomy. Okay, so you can see the cricothyroidotomy is this. So this is thyroid cartilage, and that's the cricoid cartilage. So this is where you do the cricothyroidotomy. So once you make sure, so just trauma chapter from surgical vignette, CS Dr. Faizia, which edition, any edition is fine. They haven't done a lot of change in any of the editions, so any edition will be okay. Breathing. So airway breathing. So breathing is the next part of the assessment. So making sure that whether the patient having enough ventilation. So how we can check that? One, that we can auscultate the lung to see if the patient having equal breath sound. Absence of breath sound may indicate pneumothorax or hemothorax in a trauma patient. And the other way to know about the ventilation or breathing is to do the pulse oximetry, because pulse oximetry can find out how much oxygenation is happening. Okay, so the next part is breathing. If patient's oxygen is low, you need to start the patient with oxygen. So you've done the airway breathing. The next thing is circulation. To check the circulation, we check the blood pressure and also the pulse rate. A patient is in a shock, most likely hypovolemic or hemorrhagic shock after a trauma, if their pulse is less than 90/60, plus tachycardia, which means heart rate above 100. So if we have got low BP, tachycardia, and low urine output, that will make the patient in shock. In a trauma patient, the shock can be either hypovolemia, which is basically due to bleeding, and most common scenario, or it could be cardiogenic. Cardiogenic, there are two causes, one pericardial tamponade and another tension pneumothorax. So hemorrhagic shock means that patient is losing blood. And if a patient loses blood, what happens to their JVP? So you know that JVP is the measurement of the central venous pressure, or the pressure in the right atrium. If your patient is losing blood, then definitely central venous pressure will be low because the heart is not getting enough blood. If the central venous pressure is low, what will happen to the neck vein? Neck vein will be collapsed. So in a hemorrhagic shock, the neck vein will be collapsed. Whereas if it is a cardiogenic shock, patient will have elevated JVP. Okay, so this will give you an idea. Like, let's say you have got a patient who has trauma and you found that patient is in shock. Don't just assume that it is always due to hemorrhage. It can be cardiogenic shock also. So the next thing you look at, whether the neck vein is distended or it is collapsed. If it is collapsed, likely to be hemorrhage. If it is distended neck veins, then you would think, well, it could be cardiogenic shock. Now we know that cardiogenic shock can be either due to pericardial tamponade or it can be tension pneumothorax. How to differentiate between these? Very easy. Pericardial tamponade means that this is the heart and that's the pericardium. So there is most likely blood accumulation around the heart. Patient with pericardial tamponade will not have any respiratory distress. Whereas in tension pneumothorax, they will definitely have a significant shortness of breath. And you might get other signs like loss of breath sound. You can get midline shifting to the opposite side, like tracheal deviation, apex beat can be deviated. So all of those symptoms of tension pneumothorax will be there. Okay, so that's how we can differentiate whether it is tamponade or it is a tension pneumothorax. So treatment, if the patient having hemorrhagic shock, you need to give them blood. So start with volume resuscitation, start the IV fluid and then send the blood for cross-match. Once blood is available, give the patient blood transfusion. And initial volume resuscitation is usually done by 2 liters of Ringer's lactate. Pericardial tamponade, we know the management is pericardiocentesis. So just aspirate the blood by wide bore needle. Tension pneumothorax, we know the management is like thoracocentesis with a large bore needle. So that's why it is important. If we don't know the cause of the shock, the treatment will not be sufficient. Does it make sense, guys? Like how to know what's causing the shock? Okay, so in here, this is a guideline from NSW Health. So it gives us a good idea about different kind of shock which you can go through. There are lots of shock they have talked about in here. You can go through that. There is also neurogenic shock. So neurogenic shock means that if someone get a spinal cord injury and if they have loss of sympathetic outflow. So if patient has hypotension and bradycardia, So a patient who has like motor vehicle accident and patient is in shock, but they have hypotension and bradycardia, not tachycardia, and their periphery is warm. That is the time you would think of neurogenic shock. Okay. So you can go through this. These are not very important for exam. They don't usually go for like that much like difficult questions for you in the exam. So you can go through this, not really, really important. Okay. But the main thing that usually been assessed in the exam is airway, breathing, and circulation. Next. So once we know the airway, breathing, circulation part of it, the next part is different organ will have different kind of injury. So we will start from head to toe injury of different part of the body. So first is head injury. So head injury can be penetrating head trauma, like someone might have just stabbed the head, or maybe a bullet injury. So penetrating head injury always require surgical intervention if patient is alive, because many of these patients will not be alive. If it is a linear fracture of the skull, so it's not a depressed fracture, a linear fracture can be just left alone because usually it will heal by itself. But if it is an open fracture, like you can see the bones coming out, in that case, the patient might need to be treated in the operation theater. Again, this is the only thing that you need. We don't go too much deep because it doesn't come in the exam. Just get the basic, okay? Anyone with a head trauma who has become unconscious needs to have a CT scan to look for any intracranial hematomas. If there is no hematoma, patient is neurologically intact, they can go home if family will wake them up frequently during the next 24 hours. So any patient who has a head injury and got a unconscious, that patient will require a CT scan. Now, a few other things that is important, that sometimes they can give you a patient who has a motor vehicle accident and the patient has developed base of the skull fracture. So basal skull fracture has some specific sign and symptom. So if you look on this picture, you can see if you see over here, the periorbital ecchymosis, so blood around the eyes, these patients sometimes can have Battle sign. So Battle sign is, see this mastoid bone just behind your ear? This mastoid bone can have ecchymosis or bruising. That's Battle sign. So this is called raccoon eyes. So raccoon eyes, Battle sign, and if a patient ends up having CSF rhinorrhea or otorrhea, that means they are getting some clear fluid, which is basically CSF coming out from your nose or ear. That's the sign of basal skull fracture. All right. So what do we do in basal skull fracture? So basal skull fracture, usually we would not need to do anything. Most of the time, we just need to make sure that patient is not developing any intracranial infection, and that's it. So it's wait and watch, and involving a neurosurgeon for the treatment. So treatment usually doesn't come in exam for this kind of cases because it is the job of neurosurgeon, and they don't want you to be a neurosurgeon for this exam. Okay. Now, the very important thing is to know what is epidural and subdural hematoma. We discussed this in our trial class when we discussed the tips and tricks to solve the questions, right? So epidural hematoma usually occurs with a modest trauma. So it's like even a small trauma to the head, patient can end up getting a epidural hematoma. So what are the signs, like how the patient presents? Patient who has epidural hematoma, patient initially they get the trauma, then they lose their consciousness, and patients suddenly have this lucid interval where they become completely fine, returns to baseline, and then suddenly again they go back to coma. And that is how a epidural hematoma sometimes can present. So initially they get trauma, unconsciousness, then a lucid interval when patient is completely fine, and then gradually again going back to coma, and usually get worse at that time. How we know? So if you want to rule out a epidural hematoma, the first thing you do is CT scan. And if you do a CAT scan, you will find out, so in a CT scan, the blood looks white. So if you see here, these are all the brain tissue, but you can see this convex bleeding spot. So if you get a convex shaped spot in the brain like this, that is epidural hematoma. How about subdural? In subdural hematoma, you don't get biconvex like this. You get kind of a crescent shape. So if you see here, it looks like a crescent, right? So when you get a crescent-shaped shadow, that's subdural, and when you get this biconvex shape, that is epidural. Now, any of these patients who gets epidural or subdural hematoma, patient needs to be seen by a neurosurgeon. So subdural hematoma, the force of the trauma is typically much large, and patient becomes much sicker in this patient. What happens that, remember we told that if a patient ends up having a helmet fracture after riding a motorcycle, to have a helmet fracture, tremendous force is required. And in that patient, I would choose subdural hematoma is likely possibility. But patient did not have any helmet fracture, but had a bit of unconsciousness, then yes, we can think of epidural. And yes, a lot of people think that lucid interval is only possible in epidural, but subdural patient can also have the same sequence. So trauma, unconsciousness, lucid interval, and then consciousness. So that can happen in subdural also. Okay? Acute subdural hematoma is much worse, and the prognosis is bad in that patient. Okay? But there are also patients who has chronic subdural hematoma where patient usually doesn't get really unwell, sometimes even asymptomatic. Those are common in elderly population or patients who are severely alcoholic. All right? So that's why we say that if a patient develops sudden forgetfulness, let's say a 60-year-old patient, completely fine, but over the last 6 months, patient has gradually developed like loss of memory. In any patient who has this kind of sudden onset dementia or loss of memory, you would always do a CT or MRI of their brain to rule out possibility of this chronic subdural hematoma. In sometimes elderly patient, even a small injury can cause chronic subdural hematoma. Okay? Yes, if patient is on blood thinner, that is also one of the common risk factor. Now, sometimes questions come in exam, how to manage head injury in a rural area. In a rural setting, there are remote areas in Australia where there is no CT scan available. So if CT is not available, how we can manage the patient who has a significant head injury in a rural setting? So that sometimes is asked in the exam. So the first thing we look at, what is the GCS level of the patient? If GCS less than 8 means patient is unconscious and the tertiary hospital is within 2 hours distance from the rural hospital, then you would just transfer the patient. So you do some stabilization, symptomatic treatment, and then you transfer the patient to the tertiary hospital by air ambulance. But GCS less than 8, but the tertiary hospital is more than 2 hours far. What would you do next? So a few things. One, that we need to know that if the patient is stable or not. Any patient who is unconscious, like GCS less than 8, they are not stable. For an unstable patient, doing CT scan is not indicated. So if a patient GCS less than 8 and the tertiary hospital more than 2 hours away, many times in a rural setting, the patient might need to have an emergency bar hole. It is very, very unusual. So even though questions come in exam, it is very, very unusual that a rural hospital doctor will need to do a emergency bar hole in this kind of patient. But there are remote areas where it can take 6-7 hours for the patient to come to the tertiary hospital. In that situation, the only way to save this patient is to go for a bar hole operation to remove the bleeding from the intracranial area. Okay, but if GCS more than 8, you can definitely start with a CAT scan first. So do a CAT scan, and if CAT scan shows patient having intracranial hemorrhage, then think about sending the patient to the tertiary hospital after talking to the neurosurgeon. Okay, so less than 2 hours, GCS less than 8, transfer the patient. GCS less than 8, but more than 2 hours duration. Many times, it is very tricky situation for any doctor. It's not commonly done, but it is the only thing that can save the life of the patient at that time. Okay? So still it is possible that sometimes what happens that you can even look at the head and you'll see that if there is a bleeding, especially if it is a superficial one like subdural, epidural, it is not impossible to find out the area where the patient is bleeding. Okay, because there will be swelling, hematomas. So can be done, but it is not ideally done and not very commonly done. Just remember. And any patient who has GCS more than 8, you need to find out whether the patient requires a CT scan or not. Yes, so GCS more than 8, not everyone will require a CAT scan. So we just do the CAT scan for patient who really needs it. So there is a criteria for patients who has head injury who will require the imaging. So I'll go with that. So there is a RCH guideline, which is mainly for children, but we also, like the adult indications are also pretty much same. So what are the indications? So please make sure you go through this head injury chapter from RCH. So I'll just show you a few things. So first of all, you have done the primary survey. You have calculated the GCS of the patient. If GCS is 15 and patient doesn't have any other risk factor, you don't need to do anything. So just make sure there is no other injury, patient can go home. Mild head injury with some other risk factor, the risk factors are those: severe headache, altered mental status, abnormal neurological findings. So there are few, you can go through that. In that patient, because GCS is fine, you will observe the patient for up to 4 hours, and if everything looking fine, patient can go home. But if it is moderate head injury, GCS 9 to 13, usually that patient will need a CT scan of the head and cervical spine if indicated. Okay, and definitely severe head injury, you need to consult the neurosurgical team first. So if you look over here, you don't need to know how to do the GCS. This is the definitive indication for imaging. Any moderate or severe head injury, that means GCS less than equal to 13. So any patient who has a head injury and GCS less than equal to 13 requires CT. Focal neurological deficit, like patient's one side is weak or pupil is dilated in one side. Sign of basal skull fracture, palpable skull fracture, and persistent altered mental status. Any of this is there, patient should have a CT scan of the head. Okay, so give it a read from here. So that gives us a little bit of idea, and they have given a little bit more algorithm about the head injury. So you can go through that in your own time. You don't need to calculate GCS in the exam, they will give it to you. Any question? Now, sometimes as a quick thing, we use this one in hospital setting a lot. It's called Canadian CT head injury. So the Canadian CT head injury or trauma rule gives us some of the ideas. So there are all of this. So what we do is that we just apply this. So let's say age less than 16, patient on blood thinners, patient had a seizure after activity, GCS less than 15 after 2 hours after injury, suspected open or depressed skull fracture, sign of basal skull fracture, 2 or more episodes of vomiting, age more than 65. And patient has a amnesia for the event more than 30 minutes and dangerous mechanism of injury like fall from more than 3 feet or more than 5 stairs. So this is some of the things that we normally do if easy to do. Like if you see here, let's say patient age is not less than 16, patient on blood thinner, yes. Patient did not have any seizure. Okay. So this is sometimes we just use it for a very quick thing. So we look at whether the patient has, let's say all of this is no. Okay. So age less than 16, no. Patient on blood thinners, no. Seizure after activity, no. If this is not the like if this 3 is not there, like because if this 3 is there, especially patient on blood thinner or there is a seizure after activity, after injury, usually we will go for imaging anyway. So there is no point of doing this scoring. But if these are negative, then we use this. So let's say GCS less than 15. Yes. Suspected open fracture, no. Sign of basal skull fracture, no. 2 or more episodes of vomiting, let's say yes. Age above 65, let's say yes. So that patient, even if we say others no, consider a CT scan. So what we normally do is that we just do this scoring to any patient who comes to us with a head injury, and it gives us an idea whether we want to do a CAT scan or not. That's the way to do it in the hospital situation, not in exam situation. Okay, but you can at least understand that what are the important things that we consider in that scoring system to see if the patient will require a CT scan of the head. Not everyone who has a head injury will require imaging. Okay, does it make sense? Palpable skull injury, that if you can palpate a fracture, and usually palpable means that it will be depressed fracture as well. Yes, definitely, Dr. Mehbooba. While you transfer a patient, intubation should be done because any patient who has GCS less than 8, they are unconscious, and most of the time their airway, breathing will not be intact. So intubation should be done. CT is non-contrast. No, not for CT. CT can be done in a lot of rural areas. It depends whether the rural area has the CT scan available or not. So for CT, you don't need to send the patient for a tertiary hospital. Okay. Moving on to neck trauma. Okay, so for neck trauma, first of all, remember penetrating injury to the neck. Any patient who has a penetrating neck injury requires surgical exploration in all cases. So especially if there is a stabbing wound into the neck, which penetrated, and if you see that patient having a expanding hematoma, patient's vital is unstable, patient is coughing up blood or is spitting up blood, any of those is there, patient will need a surgical exploration. For injuries, now for patient who has neck injuries, we divide the injured area into 3 zones. So zone 1, 2, and 3. So you need to know which zone patient has got the injury or trauma. So if you look over here, so we made it at the angle of the jaw. So anything above the angle of the jaw is zone 3. Anything below the cricoid cartilage, it's zone 1. And in between cricoid cartilage and angle of the mandible, zone 2. All right. Now, for patient who has these neck injuries to zone 1, first thing is you need to make sure patient is not having any kind of esophageal rupture. Patient doesn't have any vascular injury. Patient doesn't have any bronchial injury. So to do that, you need to first do some investigation. So do an angiogram to rule out any vascular injury to the neck, esophagogram, which is like a water-soluble or gastrographin swallow. You can even do a gastroscopy or endoscopy and bronchoscopy. So you do all of this to find out whether any of these important organs has got any injury. Okay, and then you decide whether any of these require repair. So that's for zone 1. Historically, all penetrating injury to zone 2 will require surgical exploration. So anything in this zone 2, patient usually will go for surgical exploration. And for zone 3, again, most of the time it is usually only it can cause vascular injury, so you do an angiogram. So just remember that zone 1 requires investigation first, zone 2 immediate surgery exploration, and zone 3 just an angiogram. In all patients with severe blunt trauma to the neck, so we know about penetrating trauma. What about blunt trauma? The first thing that we need to know that whether the cervical spine has got injured. Any unconscious patient with a blunt trauma to the neck or conscious patient with midline cervical tenderness will be evaluated with a CT scan of the cervical spine. So now we are talking about cervical spine injury. So cervical spine injury is pretty important, comes in exam a lot. So there is a RACGP guideline for that as well. So cervical spine injury, go through this guideline, but we normally do this nexus criteria. So nexus criteria has given us there are some specific sign where a patient has high risk of neck injury or cervical spine injury. So we use this nexus criteria to decide whether we want to do any kind of imaging. So the nexus criteria include midline cervical tenderness, if a patient has got altered mental status, focal neurological deficit, evidence of intoxication or painful distracting injury. So if any of this is there, and in the exam, usually you get midline cervical tenderness or altered mental status. So if a patient with neck injury, even if it is a blunt neck injury, if you see that they have given midline cervical tenderness, that patient will require not a X-ray. So this is where candidates get it wrong. They think that they will do a X-ray as an initial investigation, but X-ray is no longer the initial investigation in such patient. You will have to send the patient for a CAT scan. Okay, so the CT cervical spine will be your initial investigation if this nexus criteria is met. And this is a very good step-by-step talking about whether we really need to do the imaging or not. So you can go through that. And they say that this patient will require a CT scan. So the international guidelines support the use of cervical CT as a first-line imaging in suspected cervical spine injury. All right. So they said in here, first of all, any high risk factor, which means age more than 65, dangerous mechanism of injury, patient has neurological deficit. If any of this is there, patient will go for CT immediately. If there is nothing like that, we need to look for any low risk factor. We also need to see that whether the patient is able to rotate the neck to 45 degrees. If a patient cannot rotate the neck to 45 degrees, that patient also needs to have a CT of the cervical spine. So that's mainly all about neck trauma. So remember, neck trauma, not every penetrating injury will require surgical exploration immediately. We talked about that. So penetrating trauma requires surgical exploration in all cases where there is expanding hematoma, deteriorating vital sign of esophageal or tracheal injury such as coughing or spitting up blood. So that is the time where doesn't matter where is the injury, patient will need to go for surgical exploration. For other cases, zone by zone, we will manage accordingly. Chest trauma. So after neck trauma, the very important is chest trauma. So chest trauma, the first thing is patient can have a rib fracture. And rib fracture is one of the most painful fracture anyone can get. So there is no need of any X-ray of the chest to confirm the diagnosis of rib fracture. So how we know that patient has a rib fracture? Patient has got a motor vehicle accident, and you can either see a bad bruise on the rib case, or when you touch the ribs, it is very tender to touch. And patient says that whenever they take a deep breathing or whenever they give a cough, the patient usually gets a lot of pain in that spot. That can give you an idea that patient might have a rib fracture. In a patient who has rib fracture, because of pain, they start not taking deep breath anymore. And eventually they develop lack of ventilation in their lower part of the lungs, which results in atelectasis and ultimately pneumonia. To avoid this cycle, you have to treat the pain. So any patient who has rib fracture, the first thing you will take care is their pain. So give a strong painkiller so that the pain can be managed. And after that, Usually, it will take some time to heal by itself. The few things that you need to keep an eye in a patient with rib fracture, whether there is any complication of rib fracture, such as pneumothorax. We also need to make sure that if it is multiple rib fracture, then patient can also develop flail chest. So we need to just keep an eye that whether any of this applies in that patient. So pneumothorax, we know that simple pneumothorax can happen after trauma, and we know how to treat it, right? So if there is a pneumothorax following a trauma, what is the usual management for that patient? Guys, so it's a secondary pneumothorax, right? What will be that first? Not needle thoracostomy. So for secondary pneumothorax, usually we will go for chest tube. Yes. Hemothorax. So hemothorax is another possibility. So pneumothorax means air in the pleural cavity. And hemothorax means blood in the pleural cavity. Now, how to differentiate pneumo and hemo? In pneumothorax, patient will have hyperresonant auscultation, right? And in hemothorax, the percussion note will be just dull. So that is one of the easiest way to differentiate just by doing this simple examination, whether it is pneumo or hemo. If it is hemothorax that you suspect, both pneumo and hemo, you have to do a chest X-ray. And for hemothorax, definitely you will need to go for chest tube placement to evacuate those accumulated blood in the pleural cavity. Now, that is the main treatment, but there are some of the patients who you need to go for thoracotomy. So the indication of thoracotomy, which means surgery, is, let's say when you inserted the chest tube and immediately more than 1.5 liter blood came out into the tube. That means patient is bleeding heavily. In that patient, thoracotomy is indicated. Or over the next 4 hours, there has been a collection of more than 1 liter blood. So this is the only 2 patient where you need to do the thoracotomy. So thoracotomy is basically you just need to do a small incision in between the rib to reach into the lungs or chest. So it's a surgical procedure, whereas chest tube is just like putting the tube into the pleural cavity. So most of the time, chest tube placement is the only treatment for hemothorax, but these are the indication of thoracotomy, which is the surgery, where if you get more than 1.5 liter blood when you inserted the chest tube, or over the next 4 hours, there has been more than 1 liter of blood collection into the chest tube. Next, sucking chest wound. Needle decompression is for, like we discussed that, Dr. Ahsan, it's not for trauma patient. It's for, let's say, some patients who has simple pneumothorax, like primary spontaneous pneumothorax, or if a patient has like tension pneumothorax, then we do the needle decompression, but not for traumatic pneumothorax. But if a traumatic pneumothorax patient develops tension pneumothorax, yes, we would start with a needle decompression first. So sucking chest wound. So sucking chest wound is an important thing. So in sucking chest wound, so what happens that you will see that there is an open wound in the chest. And there is a flap. That flap sucks air in during inspiration. So there is an open wound. From that open wound, air goes into the lung when patient takes inspiration or takes the breath in. And then that flap closes during expiration. That means air is going in, but it cannot come out. So it acts as a one-way valve. The problem with this is that every time patient is taking a breath in, the air is just going in and in to the lungs. So what happens? More and more air getting collected, and patient ends up getting a deadly tension pneumothorax. To avoid this one-way valve, what we do in this patient is we just do this. So we just do a partial occlusive dressing, so 3-side dressing. So we do this 3-side dressing, and when we do this 3-side dressing, this one-way valve action is no longer there. So what will happen in that case? So air will go in and out. It will no longer collect if you do that. Okay? So sucking chest wound, the management is partially occlusive dressing on 3 sides. And when we do this, sometimes what happens that when a patient is taking breathe in, the air is no longer able to come inside through this hole. But when patient is breathing out, some of the air is coming out through this. So air is coming out. So if air comes out, that's fine. We are not worried about it. But the problem is, like, if air is going in through this. Okay? So when we do this one-way open, the air no longer can go into the chest through this hole, but it can come out during expiration. Okay? So that is the treatment of sucking chest wound. So you can see that this is how hemothorax looks like in a chest X-ray. So you can see that this whole side patient having a blood collection. Next is flail chest, very important for exam. So flail chest occurs with multiple rib fractures that allow a segment of the chest wall to cave in during expiration, bulge during expiration. What does it mean? It means that when a patient has got multiple rib fracture in more than equal to 2 places, so you can see there is a fracture here, there is a fracture here, and then contiguous ribs having multiple fractures. Now you can see there is an open fracture, right? This part. So this flap or this flail segment, what it does is that it does paradoxical breathing, which means that normally when you take inspiration, the chest wall should expand, right? But this flail segment, rather than going out, it goes in. So when a patient is taking breath in, if the flail segment is also going in, what happens? It compresses the chest, it compresses the lung. And more it compresses the lung, patient can have more and more shortness of breath and difficulty in breathing. So that is called flail chest, where a patient has multiple rib fracture in contiguous ribs, and the patient develops this flail segment, which does the paradoxical breathing. And because when the patient is taking the breath in, and this flail segment is compressing the lungs, it can cause lung contusion. And if a patient develops lung contusion, if we do a chest X-ray, we will see it's kind of a haziness or ground glass opacity throughout the lungs. So if the lung shadow looks hazy or blurry like this, that means patient has developed a pulmonary contusion. So that's one of the complications this patient can develop. So what will you do if it is a flail chest? Flail chest is very important. There are several questions in the handbook as well. So first thing is that you do a chest X-ray to confirm the diagnosis and make sure the pain management is done well. And many of these patients will require a positive pressure ventilation. So intubation and positive pressure ventilation is many times this patient might require. So there is a question that comes in exam, like you have got a patient who has developed flail chest and you have given oxygen and you have given pain management, but patient was getting better, but suddenly you found patient is no longer breathing well. So there is labored breathing or shallow breathing. If a patient with flail chest develops shallow breathing or labored breathing, that means that this is the time to go for a positive pressure ventilation. So in the positive pressure ventilation, this flail segment will no longer be able to go in during inspiration. Okay, so intubation and positive pressure ventilation will be the treatment of choice in that case. Making sense, guys? So sucking chest on flail chest, these are very important for exam. Blunt cardiac injury. Any patient who has a sternal fracture, you should suspect that they might have a cardiac injury also. So make sure you do a ECG in that patient. Rupture of the diaphragm. So if diaphragm get ruptured, the intestine can come into the chest. How we know? So if we do a auscultation of the chest, we will be able to hear the gargling sound of the intestine, or we can even hear the peristalsis. So if we see that there is gargling in the chest and we do a chest x-ray and we found the loop of intestine coming into the chest, there is traumatic rupture of diaphragm, and that patient will require a surgical repair. And surgical repair is usually done from the abdomen, not from the chest. Yes, analgesic first, because if you don't give painkiller, these patients will be in a lot of problems. So painkiller comes first in most of the time. Depends on the scenario many times, okay? Rupture of the trachea or bronchus. So when we would suspect a patient developing ruptured trachea or bronchus, ruptured trachea is suspected if a patient developing subcutaneous emphysema in the neck, or if you will be able to feel that there is air in the subcutaneous tissue. In that case, you do a chest X-ray and a CT scan to confirm whether the patient has got any air outside the bronchial tree. And to confirm the injury, you need to do a bronchoscopy. So first X-ray chest and a CT, and followed by bronchoscopy. Fat embolism. Many times fat embolism will be there in exam. So what will you do if a patient has a suspected fat embolism, and when we would suspect it? Fat embolism is common in patient who suffers from multiple traumatic injuries, especially the lower leg. So if a patient has got lower leg, like multiple comminuted fracture of the lower limb, like the tibia fibula, that patient usually has a risk of fat embolism. So fat embolism patient has a specific criteria. Usually they happens like 72 hours within this like within 72 hours of a traumatic injury. And most importantly, they will have petechial rashes in axilla or neck. So petechia because of thrombocytopenia. They might have altered mental status and respiratory distress. So three things. A patient who has a long bone fracture within 72 hours of that accident, patient develop petechial rashes in the axilla neck area. Patient is having confusion, altered mental status, and respiratory distress. You would think of possibility of a fat embolism. There is no specific way to diagnose this. So it is usually the whole scenario which gives you an idea that it could be fat embolism. And the treatment is just respiratory support, which means intubation if needed. All right, guys, so let me take a 10-minute break. And after that, we will start with the abdominal trauma. Okay. So for clear, everyone. Yep. Brilliant. So 10-minute break, guys. Thank you. All right, guys, let's start again. Fat embolism, yes, Dr. Rasifur. So yes, it's on clinical symptoms. No diagnostic test is there actually. How do we choose whether to give whole blood or packed cell? For trauma patient, usually whole blood is given. But nowadays we are giving more and more packed cell, okay? Because packed cell is much better than the whole blood. So ideally at the moment, if you want to choose between whole blood and packed cell, you will go for packed cell for everyone. If packed cell, if it is not possible to get, then, or if it's time consuming, then whole blood. Okay, abdominal trauma. So abdominal trauma is very important as well, just like chest trauma. So first of all, abdominal trauma, we need to know whether it is a penetrating trauma or a blunt trauma. And penetrating trauma, again, divided into gunshot wound and stab wound. So if it is a gunshot wound to the abdomen, it usually requires laparotomy for evaluation and possible repair of intra-abdominal injuries. So most of the patient who has, like, if the gunshot wound, the exit wound is below the nipple line. So entry or exit wound, if it is below the nipple line, it is considered that it might have involved the abdomen. So if anything like any wound, any gunshot wound below the nipple line will require a surgical exploration, which means laparotomy. Now, as part of the stab wound, it is more individualized approach. If it is clear that penetration has occurred, that means you can see the viscera or organs is coming out, that in that case laparotomy is necessary. Same if the patient is having hemodynamically, patient is unstable, so blood pressure is very low. In that patient, again, you will go for laparotomy. In the absence of above, that means patient viscera is not coming out, vitally stable, and the patient has encountered a stab wound to the abdomen. What we would do, the first thing we will look at whether or not the anterior rectus fascia has been penetrated. If the rectus fascia is not penetrated, unlikely that intra-abdominal cavity has been penetrated. In that case, nothing needs to be done. Just repair the wound. But if the fascia has been violated, the likely possibility that some intra-abdominal injury might have happened, in that case, you will need to go for surgical exploration. And if you are in doubt, you can always do a CT scan of the abdomen in a stable patient. Okay, so if a patient has a gunshot wound below the nipple line, that patient's surgical exploration is must. If a patient has a stab wound, you need to see if the viscera is out or patient is vitally unstable. In that case, again, surgical exploration. If nothing like that, then look at the anterior rectus sheath. If the rectus fascia is intact, then unlikely intra-abdominal organ has injured. So in that case, you don't need to go for surgical intervention. Okay. Blunt trauma. If there is a blunt trauma to the abdomen, and if a patient has obvious sign of internal injury, which means that patient has got abdominal distension, significant abdominal pain, and patient has got guarding rigidity on the physical examination. That means sign of peritonitis. In that case, surgical exploration is mandatory. So blunt trauma to the abdomen, patient has signs of internal bleeding, means patient having abdominal distension, significant pain, guarding rigidity. That patient might have some organ injury. So you need to go for a surgical exploration in that patient. Now, before you go for surgical exploration, you can actually do an investigation. So any blunt trauma patient, to find out whether the patient is bleeding inside, we can either do a fast scan. So the first scan is focused abdominal sonography for trauma. This is a bedside ultrasound which looks for any collection of free fluid in the abdomen. We do this fast scan in an unstable patient. For a stable patient, you can just do a CT. So for a blunt trauma patient, if you are suspicious of internal injury, first look at if the patient is vitally stable or not. If the patient is stable, do a CT scan to find out what has got injury. And if the patient is vitally unstable, then you need to do a fast scan. Now, if we're thinking about an intra-abdominal organ injury, the most common injury is either liver injury or spleen injury, and sometimes kidney injury. That's usually the three organs which gets injured mostly. So generally speaking, a patient with intra-abdominal bleeding injury from liver or spleen can be observed as long as they are hemodynamically stable. So we say that most of the liver or spleen injury patient, we can do a expectant management, which means wait and watch until they are hemodynamically stable. All right. Now, spleen injury comes in exam, so we'll give it a go with that. So how to manage a spleen injury? So spleen injury has been graded from 1 to 5. If you look on the picture, you can see grade 1 is just small laceration. Laceration less than 1 centimeter, and the subcapsular hematoma less than 10% of the total surface area of the spleen. Laceration between 1 to 3 centimeter is grade 2, and when the subcapsular hematoma is 10 to 50%. Grade 3 is either laceration more than 3 centimeter and more than 50% surface area of the spleen has got subcapsular hematoma. That's time we will call it grade 3. Grade 4 is if it is like at least 25% of the spleen is completely lacerated, devascularized. So devascularization of 25% spleen, or some of the hilar or segmental vascular injury. So the vessel that supply the spleen has got ruptured. Grade 5 is when spleen is shattered into multiple pieces. So most of the time up to grade 4, usually patient will not bleed heavily. Grade 5 usually bleeds heavily and usually they require splenectomy. Some patients with grade 4 can become hemodynamically unstable, especially when they bleed from here. And for these patients, sometimes they can try to repair these vessels, or sometimes they can even do embolization. All right. But in other patients who has stable sign and patient is not getting hemodynamically unstable, they can be just observed. Okay. So that's the treatment for spleen injury. So as long as they're hemodynamically stable, no treatment is needed. That's the baseline. Next, pelvic fracture. So if a patient has got pelvic fracture, that means pelvic bone is having a fracture, sometimes the patient can have a significant internal bleeding. So in pelvic fracture with ongoing significant bleeding causing hemodynamic instability, management is complex. So if you have got a patient who is complaining that there's a lot of pelvic pain and they can't walk or bear weight, suspect that there might be a pelvic fracture. And when you palpate the pelvis, it is quite tender to touch. The first step in a patient with pelvic fracture who is unstable is to go for an external pelvic wrapping. So you just wrap the pelvis so that it doesn't move, because every time the pelvis moves, the patient can bleed more. So the first thing that we do in an unstable patient with a suspected pelvic fracture is to go for an external pelvic wrapping. The next step is not surgical exploration, but rather angiography to identify the source of bleeding. That means we need to find out from which artery it is bleeding, or is it artery or vein. So when we do the angiogram, if no arterial bleeding is identified, the ongoing blood loss is presumed to be venous in origin, and the internal iliac artery are prophylactically embolized to prevent inflow to the bleeding veins. That means you do the angiogram. If angiogram says that the blood is not coming from an artery, then it's most likely coming from a vein. So you just embolize the internal iliac artery, which feeds the veins. Okay? So that will be the treatment for pelvic fracture with significant internal bleeding. Some of the patient who has pelvic fracture, they also might have associated organ injury, such as rectal injury, vaginal injury, urethral injury is very common in men, or bladder injury. So when would we think about urological injury in a patient? So patient who has a pelvic fracture, let's say he's complaining he has noticed blood in the urine. So someone who has sustained either a penetrating or a blunt abdominal trauma, if that patient complaining blood in the urine, you'll suspect urological injury. Any penetrating urologic injury requires surgical exploration and repair. But if it is a blunt injury, then it depends where the injury is. Like if a patient has got lower rib fracture, it can cause kidney injury as well, and patient can bleed. If a patient just says that he can see some blood at the urethral meatus, it might be urethral injury. Very important is that if a patient has urethral injury, sometimes it will be difficult for the patient to pass urine, and they can have a acute urinary retention. So if a patient has got urethral injury and then a urinary retention on the top of it, would you go for like catheterization in that patient? No. So Foley's catheter should not be inserted in that patient. So what would you do, guys? Yeah, you'll go for suprapubic aspiration. Very good. Now, if we want to confirm that if the urethra has got injured, what is the choice of investigation? Yeah, so we do a retrograde ureterogram to confirm our diagnosis. Okay, but if you suspect that, well, the kidney can also be injured, then you do a retrograde cystourethrogram. So cysto means the bladder. So if you're suspecting bladder injury along with the urethra, then you do a retrograde cystourethrogram. It's very difficult to know that whether it is coming from the bladder or the urethra. So most of the time you would go for both cystourethrogram in this patient. Okay, so that's your urological injuries. Next, burn. So far we have done all the organ injuries one by one. Burn, so burn can be chemical burn, electric burn, respiratory burn. So a lot of burn can happen. Remember, chemical burn, alkaline burn are worse than the acid burn. Do not, like let's say someone has got burn with acid. Don't try to neutralize that burn with some alkaline. Okay, so do not do that. Irrigation. So main thing that exam will ask you that if you know the first aid. First aid for a chemical burn is massive irrigation. So irrigation will be the first thing. Electrical burn. Electrical burn looks very simple. It doesn't look like there is a huge burn. It doesn't look very angry, but it is always deeper. and worse than they appear to be. Many patients might even require a massive amputation, debridement. So the concern with electrical burn is that they can have myonecrosis, so the muscle can get necrotic, which can cause kidney injury. Patient with electric burn, they can end up getting a posterior dislocation of the shoulder. So a cardiac function should be assessed in those patients as well. So do a ECG, if the patient complains chest pain, do a troponin. So do a complete assessment in that patient. Check the kidney function, making sure there is no kidney injuries. So those will be important. So there is, I think, if you go into the accident and emergency chapter in John Murtagh, you'll see a little bit of discussion about electric burns in the John Murtagh as well. Respiratory burn. So sometimes you will see that patient coming to you with, they were in a enclosed space and the building was burning. So burning building, car, plane, and they're in an enclosed space. Sometimes the flame can injure more. So it can even injure the respiratory tract. We would suspect that patient has got inhalation of the fume and causing some respiratory burn if we see that there is burn around the mouth or there is soot inside the throat. So if any of this is seen, or patient having a gargly voice, noisy breathing, in that patient you will need to go for a bronchoscopy and just to find out how much damage has been done. At some time, we will discuss about bites and stings. So snake bite comes in exam, and sometimes also like human bite, jelly sting, so jellyfish sting. So those are also in John Murtagh. We will discuss that from John Murtagh at some time. Okay. So that's basically all that you need to go through from here. Yes, so enclosed space, always we need to make sure patient hasn't developed a carbon dioxide poisoning as well. If a patient develops carbon dioxide poisoning, we need to make sure that the patient goes for 100% oxygen. Okay. So for a burn patient, what is the most important thing? Like as part of treatment after irrigation? Yes, fluid management. So hydration is very important. So how do we normally give the fluid in that patient? So there is a formula which is called Parkland formula, and we use this formula body weight in kilo, percentage of burn into 4. So, and RL is Ringer's lactate. So they will give you that what is the body weight of the patient, they will give you percentage of burn, and they will ask you how much fluid you will give in this patient initially. So the maintenance fluid is, when you do the math, the half of this amount will be given in the first 8 hours from the time patient had the burn. And the rest of it will be given in the next 16 hours. So half in the first 8 hours, half in the next 16 hours. Okay. Carbon monoxide, which happens in enclosed setting. Same kidney injury also, you do SCT, but nothing needs to be done as long as patient is vitally stable. Just wait and watch. Okay, the next thing is post-operative complications, very important for exam. So many times exam will give you a patient who has recent surgery and they will give you a complication and they will ask you what is the common cause of it or what is the treatment of it. So first of all, if a patient who has a surgery develops fever, we need to know what are the common cause of that. So during post-operative day 1, so within 24 to 48 hours, if a post-operative patient develops fever, most likely it is atelectasis, which is nothing but collapsed lungs. Around post-operative day 3, patient develops infection. So common infection is pneumonia or UTI. Day 3 to 5, common cause of fever is deep vein thrombosis or pulmonary embolism. Day 5 to 7, most likely wound infection or septic thrombophlebitis. Day 10 to 14, usually deep abscess. So it's a very important thing to remember because a lot of questions come from here. So let's say if the question says that a post-operative patient who had a recent cholecystectomy just yesterday now comes to you with fever, respiratory distress, what will be the most likely cause? If it is within day 1 or 2, most likely atelectasis. So atelectasis is the most common source of fever on the first postoperative day. So if you want, you can do a chest X-ray to confirm the diagnosis, and it can look very white like this. What we need to do? Do we need to give medication for this patient? No. So you check if the patient's oxygen is low, give the patient oxygen. If the patient has fever, give some paracetamol and ask the patient to take deep breath. So we sometimes do this incentive spirometry, where patient can take deep breath in and out, and that will do the job. So incentive spirometry is the ideal treatment for this patient. Yeah, chest physio also. So most of the time atelectasis happens that if you have given a lot of painkiller in a patient, the patient might not be taking that much of a breathing. And if the patient doesn't take breath, or then oxygen or air doesn't go into the lower part of the lungs, and it gets this bit of collapse. Sometimes it could be less painkiller. Patient is in a lot of pain, so they don't take deep breath. So having a proper analgesia can prevent it. Many patient has already like history of bronchitis, they're a known smoker, their lungs are already weak. So after operation, they can develop atelectasis quite easily. Sometimes after operation, definitely your respiratory tract is able to bring out some mucus every day. But after operation, if the patient is not bringing up mucus can sometimes block a small part of the bronchus. And that part, if the mucus is blocking this, then this part will not get any air. So it can develop atelectasis. So multiple things. So that's why we say that incentive spirometry, chest physio, all of this will help to get relieved. If you don't treat this patient, after a couple of days, this same atelectasis will become pneumonia. So during atelectasis, there is no role of any antibiotic, okay? So pneumonia, we know, UTI, we know, DVT, we know, and wound infection. So when do we think wound infection? If the wound looks red, inflamed, there is pus coming out, then you will think that the patient has developed wound infection. Deep abscess. So if a patient who has especially intra-abdominal operation and having a very high fever, chills and rigors around 10 to 14 days after surgery, think of deep abscess like pelvic abscess. And in that case, you have to go for a CT scan of the abdomen. Urinary complication, very important for exam. So many patients after having a surgery can have urinary difficulty. right? It's very common. So one, that patient has developed post-operative urinary retention, which is extremely common, particularly after surgery in the lower abdomen pelvis. So patient feels that he or she wants to void but cannot do it. So if within 6 to 8 hours after operation, patient was not able to void, ideally we put the patient on catheter. So catheterization should be performed 6 to 8 hours post-operatively if no spontaneous voiding has occurred. You inserted the catheter, but there is no urinary output. If there is no output at all, most of the time it could be just a mechanical problem, which means maybe catheter is kinked, or maybe there is a blood clot which is completely obstructing the catheter. So in such case, the first thing we do is to flush the tube to dislodge any clot. The second thing can be that patient can have a low urinary output. That means oliguria. If a patient develops oliguria after the surgery, and oliguria means less than 0.5 ml urine per kilo per hour. So the first thing that, now if a patient has oliguria, we need to think of that either the patient has post-renal failure, renal failure, or pre-renal failure. So we'll talk about this. So a patient who has operation developed oliguria and developed urinary retention. So if there is a urinary retention, that means patient cannot void, you can start doing a bladder scan. And if in the bladder scan you see that there is a lot of urine in the bladder, but patient is not able to void, then catheterize the patient. In the bladder scan, there is nothing. So there is no urine coming into the bladder. Then what would you think? So if there is no urine in the bladder scan, that means either it is a pre-renal failure or renal failure. Okay? That means either kidney is failed or there is hypovolemia. That means there is lack of fluid or blood in the body, and that's why the kidney has failed. To differentiate between pre-renal failure and renal failure, we do a fluid challenge test. To do the fluid challenge test, what we do is we give a 250 to 500 ml of normal saline bolus dose. So just give 500 ml normal saline and see if there is any urinary output. If there is urinary output after normal saline, that means patient was dehydrated before. And when you gave this normal saline, patient was able to make some urine. So in that case, it was pre-renal failure, and after giving the fluid, it's fine. But even after the fluid, there is no output. That means patient has got a renal failure. Then you do a serum urea creatinine and GFR to confirm the renal failure. Does it make sense, guys? And that's all that is written in here anyway. Next, sometimes after operation, patient can develop abdominal distension. So any patient, especially after abdominal surgery, in the first few days, they can develop paralytic ileus, which means that they might have a bit of abdominal distension. The bowel sound can be absent. They might even say that there is no passage of gas. But paralytic ileus patient will not complain a lot of abdominal pain. It is usually just like initial few days, this will happen with a bit of distension, maybe a bit of discomfort. That's it. No pain. But sometimes a patient with post-operative paralytic ileus can get complicated with a mechanical bowel obstruction. So if abdominal distension, abdominal pain, if it gets worse, even after 5 to 7 days after operation. So if the abdominal distension doesn't go away in 5 to 7 days, then you should suspect possibility of a mechanical obstruction of the bowel. Do an X-ray and you might be able to confirm the diagnosis. Okay. There is no chapter in John Murtagh for post-op complication. We are discussing all of this. We are discussing is from Kaplan Step to CK, Dr. Abdul Rahman. Trophagia, what volume of urine do we call it urinary retention? More than 700 ml. Yes, so X-ray should be done after 5 to 7 days. Okay, general surgery. As I said, general surgery we have already discussed in our class. So like Mallory Weiss TR, Boerhaave syndrome, most of these are discussed in our class anyway. Now, we're just going to discuss one thing that we couldn't discuss during our in our GIT class, which was anorectal disorders. And that is a part of surgery as well. So anal fissure, now this is from John Murtagh and you will find it in anorectal disorder chapter. So anal fissure, when would you think about anal fissure? So if a patient complains that patient has been having constipation lately and now having difficulty or painful defecation. So painful defecation in a patient who has recent constipation, we would suspect a possibility of an anal fissure. And these patients sometimes can also have bright red bleeding on their toilet paper. Now, DRE, which means digital parectal examination, is not indicated in this patient because it is extremely painful. So ideally, if you even just have a look at the anal area, you will be able to see the fissure. If there are multiple anal fissure in a patient, rule out Crohn's disease because that is one of the complications. What is the management of anal fissure? Management is conservative most of the time. So make sure patient constipation is dealt with. So high fiber diet, avoidance of constipation is very important. Sometimes you can advise them to use some local anesthetic and corticosteroid ointment. So an acute anal fissure will heal spontaneously within a few weeks using high fiber diet, siege baths, laxatives, and we can even try some glyceryl trinitrate ointment to the lower sphincter area. So basically, conservative treatment is all that needed. The only time surgery is needed if a patient has recurrent anal fissure or chronic fissure with a degree of anal stenosis. In that patient, lateral internal sphincterotomy, that means removing the sphincter, is the treatment of choice, which is not initially done in any patient. Next, perianal hematoma, very, very important for exam. They sometimes even give you a picture of it. So perianal hematoma is also known as thrombosed external hemorrhoid. So it is the rupture of external hemorrhoidal vein, and it comes as this kind of purple tender swelling at the margin of the anal canal. So tender swelling, which is purplish at the anal margin, caused by rupture of external hemorrhoidal vein. And again, it happens after a straining during passing hard stool due to constipation. So how we treat that comes in exams, surgical intervention is recommended, especially if the patient has severe discomfort. So we say if patient comes within 24 hours, you can even just do a small aspiration even without local anesthesia, using a 19 gauge needle. So you can just aspirate the blood if patient comes within 24 hours. If patient comes between 1 to 5 days, at that time, the hematoma has already clotted. So in that patient, you need to do incision under local anesthetic and then remove the clot. So incision and drainage will be the treatment at that time. But after day 6, usually hematoma is best left alone, unless it is very painful or infected. Okay, so that is the treatment for external hemorrhoid or external or perianal hematoma. Very important for exam. Perianal abscess, patient will develop significant pain around the anal area and severe constant throbbing pain. They will have fever, and most importantly, there will be hot, tender red swelling. Treatment for perianal abscess is drainage. So it's first incision and drainage, followed by antibiotic, which is metronidazole plus cefalexin. Pilonidal sinus, again, another important case for exam. So pilonidal sinus comes as, so you see this natal cleft, which is in between the two gluteal area. There is this cleft, just most of the time around the midline of this cleft, patient can develop a sinus. And it starts with a blocked hair, okay? And with the blocked hair, patient can start developing abscess there, and patient can come to you with recurrent abscess and discharge in the natal cleft. And that is what we call as pilonidal sinus. For a patient who has this kind of sinus and abscess, the first thing we do is, once the infection has settled, it is important to excise these pits. So initially, you can start with antibiotic, and once the infection is settled a little bit, this patient will need a surgery to excise the pits or the sinus tract. Sometimes if a patient, this is a very difficult thing to treat. So if a patient has got recurrent pilonidal sinus, you might need to even go for a surgery called marsupialization, where you keep the wound open, allow the free drainage of the abscess fluid or the pus, and at some point let the wound heal by itself. So sometimes marsupialization is indicated for recurrent pilonidal sinus. Internal hemorrhoid. So we talked about external hemorrhoid. Now internal hemorrhoid is very common. And we know that the most common cause is chronic constipation related to lack of fiber and inappropriate bowel habit. So hemorrhoid patient, the main presentation is that they can feel a lump coming out during a straining, during passing a stool. So we divide hemorrhoid as stage 1, 2, 3, and 4. The first degree hemorrhoid patient usually will not come to you because that's not too bad, and they can get a bit of bright bleeding. Second degree hemorrhoid, the lump will come out when patient is strained, and when they relax, it will go inside by its own. Third degree, it will come out and patient needs to manually replace it. Whereas fourth degree is the hemorrhoid will be prolapsed outside the anal area, and even with manual replacement, it will not go inside. And the most common symptoms is bleeding, which is bright red bleeding, not much of a pain. So the treatment for hemorrhoid, so initially for first and second degree hemorrhoid, the treatment of choice is dietary modification, make sure constipation is well treated, And sometimes we can try rubber band ligation or cryotherapy or even sphincterectomy. Now, sphincterectomy is only indicated for patient who has got like 4th-degree hemorrhoid. The best treatment is prevention, which means soft, bulky stool. So only time usually you would use a surgery procedure is if it is a grade 3 or grade 4, mostly grade 4, or the hemorrhoid which is strangulated, which is outside, causing a significant pain. For that patient, sphincterectomy is ideal. But other patient, conservative treatment, rubber band, cryo, those are the choice. Okay. All right, so that's all for today, guys. So as you can see that surgery is not a huge lot, but again, it is difficult if you don't know, because many of you are not a surgeon here, right? So surgery can be quite tricky, but good thing about AMC is that they don't think that you are a surgeon. They don't think you are a specialist. So they just want to know the basic life-saving measures from you. So if you know superficial, you know what can be done to save the patient. That's all that is needed for surgery. Okay. And if you can finish what we have done and also finish the surgical vignette, that will be enough for surgery preparation for your exam. Okay. Any question, guys? We don't do CT in unconscious patient. If we really need to do a CT, we'll intubate the patient first. So the other two will be orthopedics. So I've seen there is a bit of change. There will be a bit of change in the classes. I think there was 3 orthopedic class in your schedule, which I will change tonight. I'll give you an updated one. We did discuss Bartholin cyst in gynae class, Dr. Faizia. Embolization in internal aortic, no, it will not be reversible. You are not going to embolize the whole internal iliac artery. Okay. All right, everyone. So that's it for tonight. And we'll give you an updated schedules. Now, one of the other thing is, I think, so have a look on your schedule. There will be a bit of changes, especially you will not have the class on 14th, which was a question solve class. There will be a bit of change there. Okay, so I'll update that and I'll have a look and then join the classes as it is given. All good, guys. We'll finish it here tonight. Thanks all. Have a good night. Take care.